It does say in our handout here that this is a QSEN Institute showcase, and that the title is Using Theater to Move the QSEN Competencies. But it does say in my bullet points that it is student evaluation of the effectiveness of low versus high fidelity interactive learning scenarios in the psychiatric-mental health nursing classroom, and that this will help us to learn how to integrate theater as a pedagogy to integrate QSEN competencies into our classroom. So I presume that Dr. Foley is going to talk to us about his use of it in the psychiatric mental health, but I don't think that prevents any of us from using our creative minds to see how we might be able to take this to another area of our educational programs. So on that, I will take one more minute and introduce Mr. David Foley, who is Dr. David Foley, who is a faculty at Case Western Reserve.
Thank you very much. So it's a pleasure to be here, and I appreciate you turning out at the end of this long day and to sort of hear about our journey that we've been going through together. And those two people are myself and Dr. Jacqueline Robinson. She just graduated with her PhD last month, so it's a pleasure to call her that. I've been teaching in the psychiatric mental health classroom for a number of years, as well as a clinical instructor. And in case you're not aware, there is somewhat of a gap or a dearth of simulation product that's available for psych mental health nursing. It's catching up, but it has been lagging behind for quite a while. I was using some commercially prepared videotapes in my classroom, and I will just be honest with you, the students sort of were chuckling at them and laughing at them just a bit. And so I was constantly having to stop and reframe and say, okay, nurses don't actually talk to each other like that. But now let's look, so the acting for the psychopathology for the patients was outstanding, but it was actually overshadowed or overtaken by the communication between the nurses. I mean, it was very highly sanitized, very saccharine, very sweet, and the nursing staff just didn't talk to each other like that. So I started taking cameras, digital cameras, to the nursing skills lab, and using the mannequins, I staged some, in still photos, I staged some scenarios, and I was showing those to students and using Socratic narration to go through those with the students and presenting some low incidence, high risk scenarios. And then this year, with my transfer to Case Western Reserve University, Francis Payne Bolton School of Nursing, I realized that we had access to a tremendous theater arts department and began a very productive collaboration with that department. And this ultimately, resulted in using interactive learning scenarios in the classroom, and I'm happy to share all of that with you. So I have no conflict of interest to disclose, but our objectives today are to discuss key differences between what I'm calling low and high fidelity interactive learning scenarios. I'm stopping short of calling them simulations because we won't get bogged down in all the technicalities of simulations, but they're not quite simulations. But I'm finding them to be very productive pedagogical tools, very robust, that have, I think, really promoted a great deal of learning about the QSEN competencies, and in particular systems thinking, and getting the students looking at that. Also discussing the application of low versus high fidelity interactive learning scenarios, and the key QSEN competencies I focused in on for psych mental health this year were safety, teamwork and collaboration, and patient-centered care. And incidentally, for psych mental health nursing, I don't see safety ever falling off the radar. Safety is the #1 priority, and that's always a test question somewhere on my midterm and final in the class. Safety is really key, such that as an instructor, as a clinical instructor in particular, and when I'm the course coordinator, instructing and working with especially novice clinical faculty, anytime that there is a patient on the unit who is potentially violent, the first priority is to get the students away from that patient. If it was a cardiac setting, I would absolutely really want to give the student, the patient with a complex cardiac dysrhythmia, and I certainly wouldn't give the patient someone in sinus rhythm. But I would probably, in the psychiatric setting, I'm very old-fashioned. I get there an hour ahead of time at least, to screen the patients, to talk to night shift staff, and find out which patients that we probably don't want to interact with because they're potential for violence, and those that we do select as the day organically unfolds. If we need to, we can pull the students out of that situation if there's any very sensitive or complex family dynamics that the family just doesn't want a student around, or if the patient is violent, self-injurious behavior, or just appears to be extremely agitated, we can pull that patient out of there. Teaching the students how to work in teams, especially with the entire interdisciplinary team on the floor. As you know, in psychiatric mental health nursing, we don't pass medications. I've been talking to colleagues across the country. So that whole opportunity to do psychomotor skills of passing meds or doing dressing changes just isn't there. What we usually do is we do a lot of talking, therapeutic communication, and we practice new skills of assessment, such as mental status evaluation. And so and then we also run groups. So those are really what we're doing. And we need to work in teams and look at all sorts of team work and collaboration so that even in the very restrictive and sometimes potentially violent setting of the psychiatric setting, we can still provide patient-centered care. And then lastly, we will look at some key differences in student evaluation of the effectiveness of low versus high fidelity interacting learning scenarios in the psych mental health nursing classroom, because we did administer a survey. So why am I using large group interactive learning scenarios? So psych mental health, for at least in the institutions where I've worked, never really had a lot of interaction with the nursing skills lab. The nursing skills lab has historically been used to do skills-based activities, and when simulations have been used, they've really been more or less geared toward medical, surgical, pediatrics, obstetrics, and so forth. And my research collaborator, Dr. Robinson, is our simulation nursing skills manager. And I remember when I approached her and I said, would it be all right if I asked you to support me in doing simulations in the lab? So for med-surg, each group of maybe 8 students has their day, and they go to the nursing skills lab, and the students break up into pairs or even individually, and they go through one at a time through a simulation. When I asked her if she could also do this for psych mental health, she put her hands up and said, if one more person asks me to do one more thing, I'm going to have to be admitted to the psych unit. You know, she just said, enough is enough. I can't do it. I can't absorb it. So we came up with the idea and we did some brainstorming. And I said, what if you, as the lab manager, came to the classroom? And we sort of inverted or flipped the nursing resource lab with the classroom and had you come to us. And we did large group interactive scenarios, not quite simulations. I have 54 students in the class. What if you come? What if we invite the clinical instructors who are available or who are willing to come? Most of them did come, by the way. And what if we all got together and we did a really interesting classroom session where we did some theater in the classroom, where we brought in low incidence, high risk situations, for example, a patient who brandishes a weapon on a nurse who violates some pretty basic rules of proxemics. And what if we did that? And what if we did that as a theater in the round and we used acting students? And so we really looked at what was out there and we wrote scripts. I wrote the script and we really moved forward from there. So that's really where the basis of all of this came. Our nursing skills lab just wasn't able to absorb yet another entire course because, again, historically, psych mental health nursing just has not interacted with the nursing skills lab like that. So we do low incidence, high risk situations in the classroom. It's a protected environment. It's an incubator, this sort of warm, affirming space where the students can ask questions and the students can make mistakes and we can all talk and learn together. But I also think it's a pedagogical intervention that promotes active learning, particularly in 2 domains. The first is metacognition, and metacognition means that I really teach the students how to think. I tell them that my job as an instructor, as your professor, is to help teach you to think like I think in the psychiatric mental health setting. And usually I do that by externalizing my own thought process for them. And throughout, I'll say, are you really sure? Here's what I'm thinking. And you can just see the wheels start to turn and the light bulbs start to go off. So as we go through the scenarios and we do the pre-briefing, and the scenarios, and then we do the debriefing, it really does help the students to learn new ways of thinking, or at least looking at the scenarios. I also am a big fan of systems thinking approach, really trying to avoid and telling the students that we have tasks to perform, but we should not be task-oriented. We have tasks to perform, and yes, you want to learn how to pass meds and insert a Foley catheter and all those things in a very safe manner, but let's not be task-oriented. Let's figure out about time management. Let's think about the systems and quality improvement. So the scenario that I'm going to show you today, I think, is one that's ripe for systems thinking, and we can look at where the holes are and how the students could engage in quality improvement, which is yet another QSEN competency. So the types of learning scenarios that I used, first of all, are low fidelity. And again, those are photographs. It's sort of like a storyboard on the screen, going to the nursing skills lab and sort of recreating what a psych mental health patient room would look like. And of course, very sparse. We know that there's nothing in the room because safety is the highest priority. The rooms look very austere. They don't even have call bells. In the rooms, they don't have in Cleveland at least, they don't have privacy curtains. They have like a 3/4 wall because obviously the privacy curtain could be used for an act of self-injurious behavior. So I use the storyboards, and I just basically a series of still photographs, and I do Socratic narration, which means that I will set as each picture appears, I will tell the student what action is occurring. I will tell the student what the patient is saying, and then I will ask the students, now, I want you to tell me, what would you say to the patient? What would you be thinking? What would your next move be? What would your next action be? And again, framing this continuously, if we need to go get another team member to collaborate, again, very effectively illustrating that competence. So that's that importance, and I think that nothing will ever take the place throughout all the simulation and videotape products and computer simulations, and I guess I'm just really giving my own opinion. Nothing will take the place of the clinical expert in the classroom. Nothing will take the place of the clinical expert in the clinical setting. We need that person working with the students and helping to guide and shape their thinking. The high fidelity scenarios, these are scripted scenarios. I wrote 11 scripted scenarios that I've used in the classroom this semester, and I will tell you the story of that when we get to the slide about the script. But I wrote the scripted scenarios complete with stage direction and character sketches and so forth, and I gave those to the actors, but before class, the students were given character descriptions of each of the characters who were in the playlet or the situation. And they really gave a lot of very rich background. So one of the scenarios, for example, was about a young man who's 19 years old and had gradually been experiencing interpersonal difficulties and a decline in academic performance throughout high school. And he went to college, and he comes from a very high socioeconomic status family. And the father is summoned to an emergency department 100 miles away at midnight because his son was found wandering and speaking in an unintelligible manner and really has been very much decompensated. So the father shows up, and again, you sort of see that, and I guess you could process it on a very surface level that this person might have taken drugs, or this young man might have taken drugs, or he might be having a mental illness. But then when you look at the character descriptions of the toxic family dynamics that are going on behind the scenes, and the parents have been ashamed of the child and concerned about image and so forth, it takes on a whole other dimension, and it really primes the students for some very rich dialogue. So the actors at the end, and this I think is the part where we have a publication pending, and this is where we feel we've really trying to exploit the learning potential. At the end of the scenarios, the actors come to the front of the classroom and they all sit down together, and then they practice the art of improvisation. So this is the part where I have no control over. As opposed to me doing the debriefing of the low fidelity simulations at the end, where I very carefully make sure, like a dish rag, we just wring everything out of that. I just really ask the students a lot of questions. The actors come down and I say to the students, okay, what questions do you have for these characters? And they are responsible as students for reading the character sketches ahead of time. The actors use the same character sketches to practice their art of developing their characters. And it's been such a pleasure to see how rich their art really is and how they can really take those character descriptions and they can add nuances of voice inflection and body movements and so forth that are just absolutely incredible. So at the end, the students ask the patients questions, and I will tell you, for example, one thing that just absolutely surprised me is that one of the students in the classroom asked the young man who had decompensated, "Has anybody ever abused you?" And that was never anything that I had talked about with the actors. It was never anything that was included in the character description. But at the back of the classroom, I said, that's a really good question to ask. Has anyone abused you? And practicing the art of improvisation, the actor said yes. He said, "I have been verbally and physically abused by my father since I was a small child." And it just really, it was very rich, because then the other actors, the mother, the father, responded to that, and they just followed suit, and they really just created and co-constructed this marvelous narrative right in front of us. And the students then were able to incorporate all of that. So at the end of the class, then the students are responsible for going into near perfect. Individually, they do this collective mental status evaluation as a big class. They talk to the actors, they interact, and then at the end of the class, they go into a medical record product called Near Perfect. Has anyone heard of Near Perfect? Near Perfect is actually a medical record product. It's based on the Department of Veterans Affairs CPRS system, Computerized Patient Record System, which is an outstanding, very realistic product. And so what Dr. Robinson and I did was we went in and I wrote the script, she took most of the responsibility for creating the patient's near perfect chart. And the students were then responsible to sort of complete this arc by going in and doing a mental status evaluation on the patient in near perfect. And that was really something that they probably would have done in the lab had we taken this exercise to the lab. And then I go in as the instructor and I read those over and I provide the students with feedback. So it's time consuming but very meaningful, because I can give the students individual feedback on their mental status evaluation, but then it really gives me a bird's eye overview of the class to see, there's some soft spots. Maybe they're not really understanding the difference between a delusion and a hallucination, just for example. And I can reinforce that content before the next exam. So going in and having the students do an individual mental status evaluation in the record is really a great exercise. And in that record, it also has a list of the patient's medications that they were given. So to give you an example, this is just the low fidelity scenario. And I would set this up to the students, and I'm going to go through this rather quickly because it usually takes about a half hour, but we'll go through it very quickly. This is a low fidelity scenario, and it focuses, I tell the students, it focuses on 3 key QSEN competencies of the same safety, teamwork, and collaboration, and patient-centered care. But the goal is to prompt a patient to attend a psychoeducational group on a locked inpatient psychiatric unit. Has anyone taught psych clinicals before? Oh wow, that's great. So I'm sure we would hopefully agree that when the students go to teach or they take their psychiatric clinicals, there's only so much they do. They can talk to the patients, they practice skills of therapeutic communication, and they are, at least my students, I have them help to facilitate the groups on the floor, because that's something very meaningful they can do. And so we go around together, usually in pairs or in threes, and we try to encourage the patients to get up and to go to the groups. So here's something that we can do before we even go to clinicals. And so we're standing in the patient's doorway, and this is Mr. Adams, and we just offer to Mr. Adams, Mr. Adams, that there's a group that's starting, we really would like you to go. I'll be happy to walk down there with you, whatever the student feels comfortable saying to the patient. And so this is the response, and the patient looks over and maybe interacts and says, "I'd really not go," or perhaps in this case just stares at the patient. We're very chatty, and I tell the students that silence is a form of therapeutic communication. Patients communicate a lot to us when they're silent, don't they? So the patient looks over and they're silent, and then the next thing, the response is the patient turns over, and that's your response. They've simply turned over, and it's frustrating. And does anyone notice anything in the bed with the patient? Yes, so the students notice that, and so we take a step closer, and we see that this patient, and I'll just go back up, you see this is really what a psych room might look like, very, very sparse. But somehow in the bed with the patient is, does anyone recognize what that is? It's a tubing from a suction canister. And so most of the patients in this hospital, and let's think about the systems thinking. How does a patient get into the unit? They don't just come up, and there's really very, very few direct admits to the psychiatric unit. And from what I know, if a patient does come as a direct admit from a doctor's office, they go to the emergency department first so they can be searched and gowned and have their lab values checked, and if they need an EKG, whatever they might need to be medically cleared, as well as psychiatrically evaluated before they come in. So somehow the patient got a hold of that tubing, and we want to think about where is the breakdown in the system? How did that arrive? Because that's really important. That tubing, as you know, is probably about 4 feet long, and could easily be used as a weapon against self or others, and so it's very concerning. You can also see something else in the very lower right-hand corner, and that's the patient's wristband. So whose wristband is it? Is it the patient's? How did it get there? So lots of opportunity for conversation. So as we go through, I'm sort of the eyes and the ears of the nurse, and I tell the students, well, what do you think we should do? And the students say, well, probably go get someone else because they might not feel comfortable asking the patient to relinquish this by themselves, or say, and the patient is refusing to talk. Just go get some help, go get some backup, find out. But in this case, the student goes around, this particular nurse in this scenario violates a basic rule of proxemics and goes around and places the patient between themselves and the door. Very concerning. So when that happens, there's really, you've placed yourself in a very vulnerable situation. And before we go further, I'm sure all of us have a whole suitcase of stories that we can tell. All of the scenarios and scripts that I've ever written, in some form or fashion, are bits and pieces from things that I've experienced with my own 2 eyes in the setting. And sometimes I wish my suitcase wasn't as full. It feels a little burdensome. I think we've all seen a lot, haven't we? They say there's a book inside every nurse. So here's what happened in this case, that I was on the floor. I was not the nurse who did this, but at a certain inner city hospital in my hometown, the patient was thrashing around, psychomotor agitation, giving all sorts of clues that I don't want you in the room. And you usually hear a gasp from the classroom, and we see something very disturbing, and there's really no time to react because the patient's between you and the door, and the patient brandishes the knife on the nurse. So that's an even more serious concern. How did the patient get the knife on the unit? I will tell you that over the years, I've had a morbidly obese female patient smuggle a knife onto the unit by lifting her breast and putting it under her breast, and it held it in place quite effectively. And so, you have a couple male caregivers down in the Psych ED or in the ED, and they just don't feel real comfortable, doing a complete skin assessment or doing a complete search. But our Department of Veterans Affairs hospital in Cleveland has solved that problem because all patients must be wanded head to toe in the presence of a VA police officer. So, there are ways that we can improve the system and we can explore. But in this particular hospital, they did not have a metal detector. They just basically depended on a standard patient search, and for some reason, this managed to get in. Ultimately, how we found out this knife got onto the unit was a family member brought it onto the unit for the patient. And so this particular patient had a family member this patient was schizophrenic, but also had a family member who was bipolar and another family member who was also mentally ill. And there was just some very dysfunctional and toxic family dynamics, and somehow one of them got some secondary gain by bringing this knife onto the unit and giving it to the patient because the patient said that they were feeling alone and threatened and scared. So that's an example of how we can just stage a scenario like this, and the conversation can just go on for a long time. I ask the students to emote to this. How are you feeling? Just tell me how you're feeling right now. How would you empathize with the role of the nurse? Why do you think that this nurse did that? They went around, to the other side of the bed. Perhaps it's a younger nurse, and the younger nurses feel like, I just don't want to admit a mistake, or I see this, and maybe they'll think that it's my fault that this person smuggled this onto the unit, and so they went over, and that you don't have to be a hero. So we try to do the emotion, we try to look at the system. How do we think we could prevent this from happening again? Should we have called another team member over? So the high fidelity scenario, I had a bunch of these low fidelity scenarios using the mannequins and using the Socratic narration. Did it for a very long time. My classroom evaluations, this one here that I actually took it on a Sony digital camera that took floppy disks. So I think those pictures are probably at least 16, 17 years old. All right, so then I started to think that this semester, why don't we do some high fidelity scenarios? So that particular patient that you just saw was very highly religiously preoccupied. And so that's where a lot of those paranoid ideations and that whole fixed delusional belief system, that people were watching him if there was a big problem going on. So when the patient brandished the knife on the nurse, he actually said 3 words that I will never forget. Thou foul demon. He called the nurse, thou foul demon, who are you to come in here and talk to me? So that was the title of this scenario, and you'll see the difference between what occurred and what we've actually filmed. And Thou Foul Demon is a scripted scenario using acting students. And I want to tell all of you that from the outset that the goal of this last August was never to film these. We just wanted to do them in the classroom and do them and then just sort of have them maybe next year use different actors or something if we chose to continue to do this. And then when the opportunity came here to present, we talked and we said, well, maybe we should film them. So we filmed them rather quickly. But we also realized that maybe we could use these in the classroom next year, and we might want to spend a little more time filming. But what you're going to see here is just a fairly quick reenactment using a handheld video camera from a professional videographer, I might add. But I think you'll see that it's much more richer experience to do it with live action. So how we did this with Thou Foul Demon and the other scenarios were introductory faculty comments. I set the scenario up very briefly, and I only used a relatively minimal Socratic narration and debrief. I wanted the students to truly take charge of the educational experience. With the still life scenarios, it was constantly me talking, teaching them to think how I think, guiding them through, challenging them with questions, just pummeling them with questions to find out where they needed to learn and challenging them to grow. In this case, the actors are going to practice the art of improvisation, which I have a clip of that, while the students are going to ask questions again themselves to perform a group mental status evaluation. And the students and the actors are provided the character sketches. The students are able to see the electronic medical record and the medication list before they come to class. In the other still life scenarios, I did not allow them to see the medical record until the end, but now they get a chance to see it first. I also provided the actors with the character sketch, and as well as some hospital policies and things, so that they could hopefully assume the identity of the nurse. I also gave them coaching as to what nurses might do and think and act so that they could hopefully portray this as accurately as possible. So the actors are going to engage the students through improvisation, and they're going to discuss QSEN competencies and mental status evaluation, and then the students will document. So I will just tell you again that this was much more work than you would realize. It was a tremendous amount of work. It usually took me off and on maybe 8 hours to write one of the scripts. and I'll show you just a very brief excerpt in a moment. The first script, I went and made an appointment with the director of the School of Theater, and I handed the script to him and I said, would you tell me what you think? And he read it through and he said, I think this is great for a classroom vignette, but he handed me a couple of textbooks on acting and script writing, and he said, you really need to standardize these because I see you've got some stage direction in here, but stage direction should be indented and in italics, and I didn't know that. And that's if you're going to have like certain things that you want the actors to consider as a preparatory thought, you should put those in parentheses. So these are all really great, rich things to do. But I will tell you, it takes a lot of work to write a script. And then we gave the script to the actors, and I told the actors, go home and live with this script for a week or 2 weeks, and then come back and tell me what you think. The script survived probably 90% intact. But occasionally they would say, you know, I'm developing this character. I thought, that's great. They're practicing their art and they're helping to develop the character. And I just don't think the character would say this quite like that. Why don't we try it this way? And you know, most of the time they were right. There were a couple of times I pushed back because I wanted to do things in a realistic and accurate medical manner. But there were other times that I just said, okay, let's run with it and see what you think. And then other times when they acted it out, their hand movements or their body positioning was something different than what I thought, but I thought, you know, that really does work. So being willing to relinquish some of the control to co-construct the scenario with the actors was a very rich experience for me. We practiced every Tuesday morning for probably 12 of the 16 weeks of the semester. So it took a real commitment, and I'll tell you about some next steps that we're going to do at the end. So thou foul demon, this is just a very brief part of the scenario. It tells you the scenario that it's Monday at 10:15 a.m. Nurse Jack works on Center 4. He wants the patient to attend a life skills group that starts in 15 minutes. The goal is to utilize a therapeutic, goal-directed approach to encourage Mr. Adams to leave his room and attend the group. And its simulation focuses on a nurse working on a very busy psych unit who seeks to safely build rapport with a newly admitted unfamiliar patient. So you can see Mr. Adams' room, Nurse Jack knocks on the door and then says to Mr. Adams, what you'll see in a moment. So that's just an example of the script. And also, this is an example of the patient's electronic health record. I think they said there was a pointer on here. Right. So you can see that the patient does suffer from paranoid schizophrenia, and it's chronic. So it might be treatment resistant, but then they can go in and they can look at the patient's problem list, which is here. They can look at the health record, and it doesn't look like there's much else filled in, but the health record is going to have the medication list, and we also have some chart notes from the emergency department that we made up for the students will at least have some background on this patient, and so it'll prime them as to how to interact with the actors. So our three similar or same QSEN competencies are at play here. And the video, again, for Thou Foul Demon, this is a middle-aged patient with schizophrenia, chronic paranoid type. He was brought in by the police pursuant to a neighbor's phone call about bizarre, religiously preoccupied language in an apartment building's lobby area. The gentleman is very active in his local church, and in fact, he's a deacon. There's a very low level of family involvement, so there's a risk for social isolation. At least that's what I would indicate to the students. Unknown medication compliance, and little else is known about his psych history. So we don't know if we have someone who's been off their meds and very unstable. So again, this scenario, my research collaborator said it strikes her at times as being just a touch campy, so we'll disclose that. But I can tell you that in the classroom, what is not captured is when this was done in the classroom, there was an audible gasp at a couple of times, and we have a lot of international students who have come to me and disclosed that they're afraid of psychiatric patients. There's cultural variables at play. Some of them feel that it's definitely a spiritual problem. It's a battle between good and evil. And so I really had to be aware of that, and I can only tell you that this doesn't begin to capture the energy and the tension that was present in the class that day. So this is about 4 minutes long.
Good morning, Mr. Adams. How are we today? It's your nurse, Jack. Are you, ready to go to group? I think you should go. It's an important part of your plan of care. Mr. Adams, I really think you should go. All right, I'll be back in a few minutes. Come on, Mr. Adams. Group is starting soon, all right? I need to get ready to pass meds. Let's go. Come on, I'll walk with you. All right, fine, have it your way, but I'm going to have to tell your doctor, and she's not going to be happy about this. I can't promise there won't be consequences. You've been in this room way too long. Come on, let's go. I'll give you one more chance. One more, come on. It's going. All right, it's gone. Seriously, Mr. Adams, you're still in bed. Well, community group is over now. New life skills group is about to start. Come on, I'll let one slip but not two. Let's go. Come on, it's time to get moving, sir. Let's go. Mr. Adams, I really don't appreciate being ignored. Mr. Adams, is everything okay? All right, Mr. Adams, I need to talk to you, and you need to take these meds, all right? I understand you don't want to be bothered. Would you rather meet me in the hallway?
What do you want, you demon? I asked you a question, demon. Why are you here? You're going to report me? I don't answer to you, demon.
I'm sorry to bother you, sir. I can come back later if you want.
You're not going anywhere, evil one. You're here with the devil and his snares. Demon, I already rebuked you once. I asked you to leave you alone, and yet you torment me. Why are you here? I'll rebuke you again! Your day of recompense is now!
Sir?
There's nothing you can do to touch me. If one offends the eye, one can simply pluck it out. I am clothed in the helmet of righteousness. I am donned in the chestplate of truth. I am wearing the armor of God. You cannot touch me!
I'm sorry, I'm not a demon, sir, and, can you please calm down, Mr. Adams? I'm really afraid and scared of the knife you have, sir, and, anything that if you want me to listen to you, I will. I'll listen to everything you have to say, and, I love you, and the whole world loves you, and I'm here to help you, sir, and I don't want to hurt you at all.
Shut up! Punish! Punish! Punish!
I need assistance here, please.
What's wrong?
Where have you been?
Oh.
Well, call security. He has a weapon.
Security code violence! Security code violence!
Is not doing their job screening these patients in the ED. I mean, first the earbuds and now this. This is the second time in 3 months, all right? I'm calling the unit.
What's going on here? Get out of the way. Let me get the door. Where is meds? Get the other patients back in their rooms. Oh, this is bad. Wait till he calms down. Everyone needs to relax in the meantime.
So first I want to tell you that a very nice young man who is the security guard, his name is David Delansky. That's Dr. Mary Delansky's son. So in this case too. So I will tell you again, I don't think it quite survived as well as it did in the classroom on videotape. But there's so many, I don't know what you saw there, but first of all, the student. This actually was witnessed by me many years ago. And it was a young man who was a new nurse, and, it's great to be young, but he wanted to be right about everything. He didn't want to admit that he had any opportunities to improve on. And so, he wanted to be the hero, and he wanted to get all his patients to the groups. And if somebody else said, I can't get that patient to go to the group, he would usually say, I'll go get him to go. Most of the time they did. But when we did a critical incident debriefing after this, we found out what was going on. In a way, it was a good thing that we found the knife. And does anyone have any idea how the knife got onto the unit? He was a deacon in his church. Very religious man, very nice man when he was taking his meds. Anybody have an idea as to how the knife got onto the unit? Pardon me? Very close. He brought it in his Bible. And so, first of all, that prop I got at Party City, it looked really realistic. And you can see, if anyone's been to Sunday school, all the scripture that was in there like it was yesterday. I can just see him saying all of this. And it's really amazing with our patients. The spirituality is at the top of Maslow's hierarchy of needs. But because it's up there with self-actualization all by itself, it's so vulnerable when the mind becomes psychotic. It just is one of the first things to get flipped around. The spirituality that should be so comforting to patients, no matter what their religious faith, oftentimes becomes something that's very tormenting. So we found out after the critical incident debriefing, and it's a great opportunity to talk to the students about the communication style this nurse used. But we found out that a very well-meaning nurse in the ED, the patient, very manipulative, said, can I please keep my Bible? It means so much to me. Don't take my Bible. I'm a deacon. Please don't. And the emergency room doctor and the nurse said, okay, he can have his Bible. And the man knew all the while that was a letter opener that really looked, it was a cross that had the bottom of the cross was a blade. Very, very deadly, potentially lethal incident. So we had to do a debriefing. Some other things that I think is really incredible. I don't know if you heard the young man say, first the earbuds and now this. This is a companion piece, because in the other video, the security guard comes up to help the nurse, but then puts his earbuds in and sits down and listens to music, and then doesn't hear the patient start to aggress, and the nurse becomes injured. The very next week, I had my students on the clinical division, and I went an hour early, screened the patients, and we went and we did listen to report. And as we were walking back from report that there was some very violent patients on the unit, the security guard was sitting in a little alcove with his earbuds in and his music and his little phone, just listening to it. And we all went back and thought, there it is. We don't just make this stuff up, it actually happens. If you heard the security guard was saying, where are his meds? The security guard was saying, get these patients out of here. Turned out that these two nurses are very young. The character descriptions describe that both of them are on this small psych unit by themselves, and they both have less than 2 years of experience. So the security guard is pointing out to them, if this patient is egressing, why do we still have the other patients? They should be getting out of here. Do we have meds for the patient? So there's just so much to talk about here. With therapeutic communication, with body positioning, it just really turned out to be a very, very rich experience. So with the actor improvisation, we allow the patient to return to the baseline level of functioning so that we can actually interact with the patient to get as much about their psych history as possible. All of the team members, and this is interesting, I tell the students that the security guard is a member of the team. They answer questions on safety, teamwork, collaboration, and patient-centered care. Just a couple more slides, but I want you just to see just some of the questions that the students asked.
Well, I remember hearing a voice before I was taken to the hospital saying they wouldn't check my Bible. So I thought that maybe I could just put it in there. Maybe it kind of looked like a bookmark. I don't really know, but when I got into the hospital, I told them it was for my comfort. So one of the nurses let me keep it, and I was very grateful, but now that I think about it, I wish she would have taken it away from me. I was hearing voices, and they're still a little whispers, maybe one or two of them talking now, but at a level I can manage. Before there were about 6 or 7. I remember that it would just kind of become this cacophony of different voices. Sometimes it wouldn't even say anything. One of them was I try to. Sometimes money gets a little scarce, so I cut it in half, and I guess in the past couple of days I hadn't, no, but I try to. People tell me, you know, my psychiatrist and my
Generally, I felt like it was a pretty run-of-the-mill meeting. I mean, I guess I do regret touching his foot, and I had some bad placement, I guess, but I just try to establish a personal connection with my patients, but I might have gotten a little too personal with this one.
Pretty poorly. We just don't have I don't know, I feel like security's not really always there when we need them, and then I was really flustered because I didn't really know what was going on, so I was just getting kind of screamed at by everyone, which isn't really fair, so.
Well, I think we do our jobs pretty well. We do the searches usually, and we're pretty thorough with our searches. And she called the code on the radio, which is standard. We're supposed to call the code through the radio, and I showed up on time and thought we did our job pretty adequately.
Didn't the guy have a knife?
Well, he did have a knife.
Didn't you say you just searched him?
Well, I did search him, yeah.
And you missed the knife?
We're unsure how he had a knife in there. I mean, we body searched, checked everything, and he just had his claw.
Well, that's a breakdown in communication. I think you got through with a knife.
So how would you critique the screening process in the emergency department?
I think screening possessions, yes, but in this case, it was not a security officer that allowed him to carry his Bible in. It was a nurse. It was not a security officer.
I don't know, I can't speak for the nurse, but I'm wondering if she, went through security first, and security missed that, and then if he already had the Bible, and then asked, can I keep the Bible, because security didn't take it in the first place. I don't think that's like a nurse thing. I think that's a together collectively we made a mistake thing, but we just wanted him to feel comfortable, and that would be good for his psychological state. I can't speak on behalf of the nurse, but I think this was just a misstep for everyone on the team.
So on that note, let me just tell you that I think that, again, I wish you could...
I think so. I think, we need to be clear on who does the first kind of search, and so I think it should be security and then nurses, but hopefully the nurses don't have to find anything that the security guards missed. But yeah, if we could all sit down as a team, maybe have another meeting and talk about kind of what the procedure should be, so we're...
There we go. So I think that, if you could see the actual, improvisation, it was very rich. And I knew we were onto something because the students, when they turned in their evaluation forms, their surveys, they wrote, there was no lines where they should write qualitative feedback, but they wrote things like on the male nurse, Nurse Jack's performance was horrible, he should be fired. Things like that. I mean, it was really incredible. I feel sorry for this patient. I mean, so then when I read those, I went back the next week and followed up with even additional feedback to the students. So because this was an evaluation simply of 2 teaching methods, the Case Western Reserve University IRB declared it exempt from further review. So I was able to administer the survey to the students. And I just found out a couple things that I wanted to just share with you. So everyone in the class participated. We left and one of our student interns administered the survey. The students stated that the high fidelity scenarios or the videos enhanced their knowledge of psych mental health nursing more than low fidelity scenarios. However, the students stated they felt more comfortable providing input to the class discussion when I was Socratically narrating during low fidelity scenarios. So I think that I said, good old dad or whatever, there's a place for us still. They rated the entertainment value of these scenarios and other questions just off the Richter scale. So they rated a traditional lecture format very low. Low fidelity scenarios with the still life, moderate, but they rated the high fidelity scenarios as extremely high. And they also felt that the high fidelity scenarios much more accurately captured the patient's psychopathology, which I thought was very encouraging. So we're asking the students with these high fidelity scenarios to take much more charge of their educational experience. They need to come to class prepared. They need to read the character sketches. They need to look through the near perfect record. I asked them, once they look through the near perfect record, to find out which disease process will be highlighted. I expect them to go back to the textbook and the classroom notes and come really armed with a lot of information so that they can really be much more active learners in the classroom, and then follow that up and close the loop with the near perfect evaluation. So I believe, any questions? Please.
On the near perfect, did you say that students prep by reading the character sketches and looking at the medication list in near perfect?
And there's some, yes, and there's some ED notes in there and the patient's problem list, yes. And Dr. Robinson is very good at that. She's our simulation lab manager, so she developed that in near perfect. Yes. And our students pay a fee, a yearly fee, to use near perfect. I wanted the actors to be able to go into near perfect, the acting students, but they would have had to pay a $50 per year fee, and so we just gave them the character sketches. So yeah, but it's a great program. It's near perfect. It's an actual electronic medical record used in all the VA hospitals. So another question.
Do students receive any credit, the actors receive any credit for their participation?
Yes, that's a very good question. Well, the credit they received this semester was, at the very end, I surprised them and took them out for a fabulous dinner. So. But I will tell you that I'm working with the director of the theater arts program to develop a 2 credit hour class called medical theater. And we all know, for those of us in academia, that's probably going to take another year to get that through the curriculum committee at the university level, but we are working on that. Absolutely. And I also, Dr. Delansky said, make sure that you give them a blurb so that they can put it on their resumes. I will tell you that these acting students are hungry to have something that they can show, and they said, since the videos are on YouTube, they can actually have that as part of their resume. Yes?
Doesn't Case Western has a medical program? Are they not using standardized patients, and are those standardized patients, so the theater students could become standardized patients, this would be like almost an intro, or could you not partner with the theater and find learning objectives that you're meeting as part of their learning outcomes in doing this and make it part of their assignments and have a shared assignment?
We could definitely do that. When I think of standardized patients, like I would think of Jacob, who is the gentleman who played the schizophrenic patient, having the student go in and interview that particular patient. This is actually a cast. We're putting together an entire cast, and I will just tell you, this is a lot of work. And to do the props, and we had a sheet with Post-it notes on the wall in my office to make sure we had all of our props and all of our scenes. And then when we went to film it, the videographer came over, and it was another learning process about blocking the scenes and making sure that we had everything. Videotaping something is hard because you had to videotape every scene at least 3 times. Once from afar, and then once from the perspective of the patient, looking back at the nurse, and once from the perspective of the patient, or the nurse looking at the patient. And then he went back to the video editing room and edited it all together. And that where he's knocking on the door, that's actually a closet. So he's going in, and then we stopped, and then he went back and but when they edited it all together, it's just, you can't tell, it's really great. So yes, please.
So in your case, when you had theater students come in and did like an A patient illustration, more the standardized stuff. But I wondered if you had any situations where you had a couple of students that were triggered and through themselves, and the staff wasn't prepared for that. The supporting staff was not really prepared for that. Do you have anything in place that you can talk about?
Well, I can only tell you that, when I wrote up the IRB for this, I said that I'm going to use these in the classroom whether or not they approve us to do the study or not. I'm still going to use them as a pedagogical tool. And I tell the students, I've had students when I've taught first-year med-surg years ago, And when I was teaching about cardiac issues, somebody got up the room and left because her grandfather had passed away from a heart attack. So something is going to trigger someone. When I was teaching about eating disorders this semester, I had a student show up and she said, I just wanted to apologize because I left your class 15 minutes early. I really didn't notice because she left when my back was turned. But then she sends me this long letter about someone she knows has an eating disorder. And then the international students in particular were the ones I was concerned about because some of them believe that psychiatric mental illness truly is a religious problem.
Well, and I always tell them, you are free to opt out, right? And I know that raises some concerns in nursing, but I just feel like someone has to, especially if someone's had, we've had students that have been hospitalized, and so approach that with some sensitivity.
Absolutely. And I always do a disclaimer. I tell the students if anything's uncomfortable, you're free to leave. There was a final exam test question where I said pick one of the scenarios and write 3 paragraphs regarding how you notice QSEN competencies at work and how you would utilize QSEN competencies to improve patient care or the system or something like that. And most of them did a really great job. And I know that when the clinical instructors were there, I kind of fast forwarded through the improvisation, but I started asking them about the QSEN competencies and tell me where you saw them at play and the systems thinking and safety and teamwork collaboration, and the conversation was very rich. So, somebody else? Yes, please.
I was concerned about the student that was playing, the theater student that was playing the part of the psychiatric patient. Are they screened in any way to make sure that this isn't a trigger for them? Because they really, if they're doing nothing acting and they're really getting into that, I just wasn't sure what the screening you did for that.
Well, the reason I selected him was because he's actually, even though he's a theater student, we employed him as a teaching assistant in the School of Nursing. So he was very well known to us, and I brought him up to my office and we talked for probably 45 minutes. And it's amazing you should say that because he said, well, maybe I should go out and find some videos of hallucinations and really immerse myself. And I said, no, there's no need to do that. So I coached him through the process, but these acting students take their craft, and I've grown to respect it because they take their craft very seriously, very seriously. As a matter of fact, most of them said in true method acting fashion, for a week before the performance, they did not speak to each other, even though they're in class, because when they interacted with each other on the performance day, they wanted it to be very fresh. And they thought if they would be around each other, so they kind of moved to different parts in their classroom and they avoided each other. Because they said that's what Meryl Streep does. She refuses to interact with the other actors on set so that if she yells at someone or has a performance that it's going to be received in a very fresh manner. So it's a really interesting process, but it's very time consuming. I can think about when I was in school, the teacher would hand out slips of paper to us and say, go act out this role play in the front of the classroom. And this is quite far beyond that. And I was really surprised how much I've learned about the art of acting also. So, any other questions? My scenarios, actually, I will tell you, I'm in discussion with a company for those. But I will, the one scenario I will tell you that I wrote on Thanksgiving evening was about a transgender patient. And Mary Delansky's son, the security guard, actually was courageous enough to play the transgender patient who was humiliated on a medical surgical unit, and that again, real life, reality based, and then commits an act of suicide on the unit, or suicidal ideation. But in the original script, the patient passed away, but as an act of sensitivity, we chose to bring the code team in and resuscitate the patient. And it was really neat because the patient's wig falls off and they refuse to touch the patient, and the patient has their stash inside their wig. And so as they're resuscitating her, the wig falls off, and the same people who are making fun of her actually, as they're coding her, they put the wig back on her, sort of as an act of contrition, and the wig becomes a metaphor for inclusion. So lots of interesting things. So if anybody would like to collaborate, I believe this PowerPoint will be on the QSEN website. This presentation will be on the QSEN website. I'd love to hear from you. All right. Thank you so much.
Thank you.